Kia ora koutou. Welcome to tonight's Goodfellow Unit webinar on vaccinating older adults as part of routine care and travel medicine. My name's Danusha Emalang, Special GP, and tonight we have Dr. Jenny Visser with us. Jenny needs no introduction to the travel medicine community. Jenny is the lead academic for travel medicine, postgraduate studies, and senior lecturer, Department of Primary Healthcare and General Practice, University of Otago, Wellington. Jenny's background is in general practice, having been a GP in Wellington prior to specialising in travel medicine. Her research interests include travel health needs of long-term expatriates and expedition medicine. She also works part-time in clinical travel medicine in Wellington. This webinar is sponsored by an unrestricted educational grant from GSK. The content was developed independently by the Goodfellow Unit and our expert speaker. Thank you, Jenny.
Thank you. Thank you for that lovely introduction. Thank you. So my brief today is to talk about the older traveller and specifically looking at some of the respiratory illnesses, but I thought I'd bulk this out into a more general presentation around the older traveller. I like always starting with a quote if I can find one, and here's one from Michael Palin, who's that wonderful author. Once the travel bug bites, there is no known antidote, and I know that I shall be happily infected until the end of my days. And hopefully we can make sure that that travel is as safe as it possibly can be. I thought we'd start with a little bit of a scenario, just thinking about the challenges that this traveller in the scenario would have. So an 81-year-old travelling from Wellington to London to visit his daughter via Dubai. He's an experienced traveller, or has been, but hasn't travelled in the last 5 or 6 years, really since pre-COVID. His mini mental state examination has been relatively stable, but at around the 22 to 25 over the last few years. His medical history, he's got type 2 diabetes, hypertension, dyslipidemia, medications, he's on metformin, glipizide, isophane, which he's only just started in the last few months, a bit of aspirin, atorvastatin and losartan. He's got a bit of OA in both of his hips. So his son drops him off at Wellington Airport. He negotiates that, okay, gets up to Auckland all right, then has to find the transport from the domestic terminal to the international terminal, relatively smooth, going through passport control and security now at Auckland Airport, and finds his way to the departure lounge in Auckland, which is not that huge an airport. Lands in Dubai after a 17-hour journey. Oh, sorry, it's from Wellington, 17-hour journey to Dubai, and hadn't realized just how big Dubai Airport was. And I don't know how many of you have transited in Dubai, but it takes quite a lot of walking from where you land. You have to walk quite some distance to then queue up with a whole lot of people to go through security, then find your gate, because often that's not known at the time that your tickets and your boarding pass has been issued, and then find your departure lounge. And it can be a good half hour, if not longer, walk. So our 81-year-old traveller undertakes that. He's pretty tired. His hips are starting to hurt. He's overwhelmed a little bit by the crowds and things, but he ends up in the right departure lounge, and he's so tired from the journey that he falls asleep. Now, luckily, there's a last minute gate change, but somebody else in the waiting sees him there snoozing, wakes him up and makes sure he gets to the gate. But this increases his anxiety again. So then he flies into London, and en route he'd taken his oral medication because he thought, gosh, I'm about 24 hours after New Zealand time. But it's a bit of a hassle doing the insulin. I'll wait till I get there. And while he's waiting for his luggage, he gives he medicate he gives himself his insulin, but he in his slight confusion and tiredness and things, he dials it to 15 units instead of 5, and then he has to wait for his luggage and becomes dizzy and faint and have a hypo and ends up with the ambulance being called. So let's just think about this person and some of the ways that we might be able to help him and manage his travel a little bit better. But first we need to define older age. The United Nations, for purposes of their reports and things, still defines older age as starting at 60 years. Many high-income nations use 65 years plus around the time of retirement. The World Health Organization African region defines older age as 50 years plus because of the shorter life expectancy. But I'm sure you can all see we can't just lump everybody over 60 into the older age category if that indeed is the cutoff we're going to use. There will be the young old, the medium old, and the very old. There are lots of different definitions, but obviously a frail person well into their 80s is going to have very different health needs to and travel health needs to somebody in the early 60s. So what is aging is defined by the World Health Organization. At a biological level, it results from the impact of the accumulation of a wide variety of molecular and cellular damage over time. It leads to a gradual decrease in physical and mental capacity and a growing risk of disease and ultimately death. These changes are neither linear nor consistent, and they are only loosely associated with the person's age in years, and the diversity seen in older age is not random. So there are differing rates of aging. What is the association between someone's chronological age and their physiological age? And it's really interesting that one of the best articles I found on this was actually written by an economist and published in a Journal of Economics, and talking about the limits of chronological age. And their conclusion was that they couldn't find a strong correlation. So continued reliance on chronological age as a proxy for physiological functioning might impede the ability of society to fully harness the benefits of increasing longevity. So it's not all negative. We need to think about there's a difference between somebody getting older. I mean, so chronologically, every year we get another year older, but that doesn't necessarily mean that we're aging significantly, although there may be periods where we do and more rapidly and we don't. But also, just because you get old doesn't necessarily mean that you will have an age-related illness. And we can look at this, the correlation between biological and chronological age. If there was a perfect correlation, there would be that line in the middle, but some people will age more rapidly biologically than others, and others will age more slowly. And then you have this gap in either an accelerated or a decelerated biological aging, which is influenced by many factors: psychosocial factors, stresses, your environment that you're being brought up in or that you live in, lifestyle parameters, as well as genetic risk and resilience. So we have to look beyond chronological age and don't assume that everyone who is older in years is necessarily physiologically aged as well. But inevitably, aging will catch up with us at some point in time, and every organ of the body, even in the healthiest person, will start showing some of the signs of aging. So in the brain, reduction in brain volume, deterioration of the myelin shell, and a shrinkage of the temporal lobe and hippocampus, and the lungs, reduced cough strength. The cilia aren't as good at clearing infections. You have decreased alveolus elasticity, and you just can't take in as much air as you have in the past. Gastrointestinal, decreased microbial diversity, gut motility, and the integrity of the intestinal barrier. Musculoskeletal, more brittle bones, less muscle mass, in the heart, reduced cell number, and decreased strength and elasticity of the cardiac walls. And common features across all those organs is decreased cell number and function, change in tissue structure, and increased chronic inflammation. And the important point here is that another very important organ in the body is our immune system, and it ages, even in the healthiest of adults, it ages as we get older. So all these factors feed in. You get accumulation of senescent immune cells, a dysregulated immune system, this chronic inflammation, the thymus becomes involuted and functions less well. And all of these, plus all the other things that happen as we age, accumulate in an impaired immune function and low-grade chronic inflammation, meaning that you not only are more prone to infections as you get older, you're less able to fight off the infections, but you're less, also you have reduced vaccine efficacy as you age as well. And this is the term we use for immunosenescence. So the idea that the immune system is just becoming less effective on every front as we get older. And this chronic inflammation has been called inflammaging. And the two interact to reduce the older person's ability to fight off infection and mount an effective immune response. If we look just at the T cells, for an example, just one part of the immune system, where you have in the young person a normal thymus with with few senescent T cells, lots of naive T cells, so ready to encounter and take on new antigens and high antigen recognition, which reduces susceptibility to infection and increases response to vaccines. But as we get older with that thymic involution, there's more T cell senescence, less naive T cells, and less, and recognition of the antigen becomes slowed to increase susceptibility to infection and decrease response to vaccines. So overall, some of the challenges that are facing older adults are reduced physical capacity and resilience, reduced cognition, and whether at the extreme end, people with dementia. But even if you don't go down right to that extreme end, your ability to cope with memory, with remembering things and multitasking and avoiding cognitive overload is reduced as you get older. All those challenges around immunosenescence. Older people are also more likely to have pre-existing medical conditions, more likely to be on medications, which can be a challenge in travelers with drug-to-drug interactions, especially with malaria chemoprophylaxis. Specifically during flight, there's an increased risk of travel-related venous thromboembolism. Older people also have reduced tolerance to both heat and cold. And then there may be issues with travel insurance, both with getting coverage for pre-existing medical conditions and the increasing cost of insurance as well. Now that all becomes a little bit depressing, so I have to remind myself about some of the amazing trips that my older travelers have been undertaking, and these are just a few people I've seen in the last month or two. An 85-year-old going off to the Central Asian stans, a 79-year-old going to do some work for a biography in Uganda, a 72-year-old who's going to be spending some time in Madagascar, including going camping, and a couple of very young older people in their early to mid-60s who are doing a supported cycle trip from Nairobi to Dar es Salaam. And I'm sure you've all seen older travelers doing amazing stuff in your practices as well. And it's really important to not lose sight of some of the beneficial effects of travel on aging specifically. We all travel because we love travel and we know there are some benefits. But this was a really interesting study published very, very recently, and it was taken from a longitudinal study following Americans in health and retirement. And they measured baseline cognitive function and then repeated it 6 years later. And when they corrected for all other confounding factors and the like, found that those who had traveled had higher cognitive test scores 6 years later. So aging does keep your brain young, which is reassuring. And it's not surprising. This was a survey undertaken by New Zealand seniors asking about travel and their motivations. And older travellers want all the same things out of travel that everybody does, and overall happiness being their number one driver to get out and travel. There are also some positives of being an older traveler. If you're more There is some evidence, although it's conflicting, that older travelers are more likely to present for pre-travel care. Certainly, they're more likely to have an ongoing relationship with a GP because they may have a pre-existing medical condition. Hopefully, you'd like to think that that older travelers are a bit more wiser. They have more life experience, more travel experience, which means they may make more sensible choices around travel. There is, of course, a healthy traveler bias in older travelers. Those who are really unwell and very frail won't be traveling. But older travelers often have more time on their hands, especially if they're recently retired, so they can have longer trips. There's not as much haste about getting from A to B. They can avoid peak season. They can travel in the shoulder seasons, which means they may be in a better position to avoid those extremes of heat that we're seeing increasingly more often in some parts of the world. And they tend to have a bit more money, so they can make better choices around their accommodation and the like. We live in an aging world. We're going to see more older travelers. So the number of people being born and the people under the age of 5 will be overtaken by those over the age of 65. And this was the World Population Prospectus in 2024, predicting that by the mid 2030s, there'll be 265 million persons aged 80 plus, which will be more than the number of infants, so those under the year of 1. And by the late 2070, sorry, the number of persons aged 65 and higher is projected to reach 2.2 billion, which will surpass all children, all those under the age of 18. So we're going to see more older travellers. This has been the growth that we've seen in tourism over the years, and then that huge dip, of course, in 2020 with the onset of the COVID pandemic. It's now bounced back, and the 2024 figures, it's almost back to the 1.4, or as pretty well as back to the 1.4 billion travellers per annum. But what we want to know, or what would be of interest for this talk, is how many of those travellers are older travellers. And I just looked at European data, and their share in tourism nights, those over 65 accounted for 23%, and those between 55 and 64 accounted for 18%. So together, they accounted for 41% of all tourism nights. So a significant proportion of all tourists. So what's being published? What do the articles tell us about travel-associated illnesses in older travellers? So this first article was taken as was data from the GS Sentinel clinics, and GS Sentinel is a network of clinics run through the internet. The connections all run through the International Society of Travel Medicine, and they all feed into this database. Any ill travellers they see post-travel or during travel, they fill in information and send it to a centralised database. So this is from 1997 to 2008, they compared the proportionate morbidity of specific diagnoses in those aged over 60 years, and there were about, I think sorry, I have to move it was about 7,000 in that age group, compared to a group of over 63,000 encounters in travel in those aged between 18 and 45. The mean age of the old group was 66 years, but ranged from 60 to 98, and 22% were older than 70 years of age. So, not all very young, old, a real mix. So on the left are the things that those who were over 60 had less of. They had less acute diarrhea, less upper respiratory tract infections, less influenza and flu-like illnesses, less dengue, less non-severe malaria, less genital infections and STDs, and less schistosomiasis. What they had more of was lower respiratory tract infections, was high altitude pulmonary edema, arthropod bites, rickettsial infections, more acid reflux problems, more trauma and injury, and more urinary tract infections. They also were more likely to have severe malaria, pulmonary embolism, cardiac events, and to die. They made shorter trips. More of their trips were prearranged or organized trips compared to the younger group. More of them traveled to Europe and the USA, but they were less likely in this study to have sought pre-travel advice, but that could well have been influenced by the fact that more of them were traveling to non-tropical, low-income countries. Another study, this was a post-travel study of short-term travelers, less than 1 month of duration. And again, they compared, this was an Israeli clinic, compared those over 60 with those aged from 20 to 30 years. The older travelers were more likely to take organized tours. And this study showed that they had less illness during travel compared to the younger cohort. almost 20% in the older travelers versus 34% in the younger travelers. Diarrhea was the most common symptom reported in this study, and it was about 10% of the older travelers versus almost 25% of the younger travelers. They found that the older travelers were less likely to drink tap water and any opened drinks. Few of them purchased street food, and they were more likely to be compliant with their antimalarial chemoprophylaxis, but they were less likely to use insect repellent. So their conclusions was because elderly travelers tend to comply with health-related recommendations better and use less risky travel modes, their risk for illness during travel was lower. This is another retrospective analysis of older travelers attending a travel health clinic, and really the aim of this study was to find out how many of them had pre-existing medical conditions. In this clinic, it represented about 5% of all their pre-travel clinic visits. 80% were traveling with somebody, most were traveling for tourism. Now, they said that they found that nearly 80% of people who came, of older people who came to their clinic, had a pre-existing medical condition. They didn't break that down in any great detail. I found that quite a surprising amount, but I went back and checked on that, and that's certainly not typical of other studies. But what was interesting and was typical of other studies was the top three were hypertension, dyslipidemia, and diabetes. Is there anything we can do to predict which older travelers are more likely to run into problems when they travel? And this was from the Netherlands, a group that have done a lot of research into travelers. And this was a prospective study of 447 short-term travelers going to tropical destinations, and they were all over 60 years of age, but 28% of them were over 70 years of age. So they s they recorded baseline data, so they used hand grip strength as a surrogate for a measure of general frailty. They did cognitive tests, the 6 CIT, and they did comorbidity tests, including the Charlson Comorbidity Index, the CCI score. The median cognitive and comorbidity scores were 0. So this was a very healthy group of older travelers, and the median grip strength was 34 kg, again a sign of generally good physical fitness. In their study, they found 40% had pre-existing illness and 16% used 5 or more daily medications. About 5%, hang on, I've the body, I have to remember I said, yeah, about 5% reported an exacerbation of their pre-existing condition during travel. Again, very high compliance with malaria chemoprophylaxis when it was prescribed. The illnesses during and shortly after travel, respiratory tract infections were common, gastroenteritis was common, peripheral edema was common, dehydration, and injuries. And what was also interesting in this study was that there was an improvement reported in mental health scores during and post-travel, and improvement in self-perceived and actual physical health during and post-travel, again emphasizing the benefit of travel in this older age group. So what about those predictors? Was there any correlation between their baseline measurements and whether or not people were more prone to have travel-related problems? And And the ones that they did find was a higher comorbidity index, which isn't surprising, is it? If you've got someone who's got lots of illnesses, then that's going to put them at higher risk of health risks while traveling. And the higher number of daily medications, which again ties back to comorbidities. Interesting also, more tropical travel experience, which was a predictor for having a travel-related health issue, probably because they were all going to tropical destinations, but perhaps these were people going to more exotic destinations, or but they were at a higher risk of traveling into malaria risk zones and things than others. Longer duration of travel and destination: North Africa, Southeast or Southeast Asia. And interestingly, if they used a mobile phone and were active in social media, that was a predictor for them to have higher travel-related morbidity. And the authors of the study did not um, attempt to explain this. I don't understand why, but I found it very reassuring because I hate social media. So I predict that I'm going to be a much safer older traveler when I go to the tropics. And interestingly, the grip strength was not a predictor. So having lots of comorbidities prior to travel and taking lots of medications are probably the two key ones that might help us. And it's common sense. It makes sense that those people are going to be more likely to have an exacerbation. So, as summary, a little bit we know about older travelers. It's not a huge amount. They have a different range of travel-related morbidity compared to younger age groups. Many have a pre-existing medical condition, some of whom will have an exacerbation during travel. They may have lower rates of travel-related illnesses. They travel differently because they choose safer types of travel, seem to take fewer food and beverage risks, and they're more compliant with their malaria chemoprophylaxis. The interesting thing, of course, with those studies was that they weren't compared with a cohort of non-travelers in that age group. So if you looked at things like injuries and an exacerbation of their medical condition and the like, what would have been happening if they weren't traveling? Is it more or less during travel? Okay, so let's move on to some of the respiratory risks for travelers in general, and how impacts particularly on the older traveler, and looking at all of these forms of transmission: droplet, aerosol, direct and indirect contact. You can see all of these will be increased, the risk of these increased in travel, because you're often traveling in enclosed spaces, crowds with lots of other people, coming into contact with surfaces that many other people have come into contact with. And so the risk for infection could well be increased, not surprisingly. And at the base of this, of course, is the reproductive number. And when we look at a number of diseases, I mean, measles tops the chart, but from a particularly a respiratory point of view, pertussis is very, very high. Varicella is pretty high. Then respiratory syncytial virus, much lower, that 1 to 5. Common cold viruses around the 2 to 3. SARS-CoV, COVID-19, lots of different studies. Some of them put it early in the pandemic, it was up higher than this, more like 3 or 4, but seems to be settling around the 1.4 to 2.4, and influenza ranging from 1 to 2. So these are all quite infectious diseases, and it's not surprising that you're going to be exposed to them during travel. The one that's had a lot of work done specifically in travelers is influenza, because it's been around for such a long time. It's very common. In one study in Dutch travelers, 15% seroconverted during travel, but not all of them were symptomatic. 6.3% of all the travelers were symptomatic with an influenza-like illness. Swiss travelers, seroconversion incidence of about 1 per month. And another Dutch study, 7.2 attack rate of influenza with an incidence of 0.9 per month. And then in Australian travellers, 28% of travellers had any acute respiratory infection. The incidence of any acute respiratory infection was 3% per month, and influenza was 1% per month. So that influenza figure of about 1% per month is quite consistent. And again, we don't know how we can compare. There aren't good studies that look at, well, what's the risk of this occurring while you're traveling versus while you're traveling while you're at home. But undeniably, if you get ill while you're at home, it's probably going to have less impact than if you get ill while you're traveling, because you're away from your normal, first of all, it's a nuisance, it's detracting from your holiday. But if you get sick a long way from home in an unfamiliar healthcare system, and you have to negotiate that and ring your insurance and things, and in some countries, the support, the medical support may not be of a standard that you're used to at home. So there's probably some additional risk if you get sick while you're traveling. This was a really interesting paper that was published in 2023 that looked at the seasonality of influenza and how important that is to take into account when we're advising our travelers, because obviously many travelers will be will be going will be traveling into another hemisphere into their winter months, and the influenza vaccine that they had early in our winter will no longer be protecting them for a northern hemisphere winter, a northern hemisphere winter, because that's now into our summer. And it's not quite as I'd always thought of this as a very even, north of the equator versus south of the equator, and it's not quite so straightforward. You have to take into factors around whether they're in the tropics, the general heat. So and around the equator, you've got some countries in the green where you have year-round transmission of influenza as well. And I didn't have time to make my own slides. So I've just come back from the International Society of Travel Medicine conference in New Orleans, and there was a workshop given on exactly this topic. And Prof. Robert Steffen, who's one of the grandfathers of travel medicine, was talking about influenza and saying how important it is, particularly in cruise ships, where there are studies that indicate very high transmission rates on cruise ships. And not only is this a risk to the person themselves on the cruise, but then they can seed infections in the ports that they visit. And there have been a number of out of season influenza outbreaks in Alaskan ports in this summer months, but being brought by Southern Hemisphere people coming from our winter seeking a warm summer holiday, but bringing their influenza with them and seeding it into the local population. And really, he made a very strong call for having a very low threshold to recommend influenza vaccine for all our travellers, and that this is often neglected by healthcare professionals, and there's a low acceptance rate on the part of travellers. For the other acute respiratory infections in travellers, there is a lot less data. COVID-19, there was some anecdotal information suggesting about a 4% infection rate on cruise liners. And when they looked at doctors and nurses, health professionals who attended the International Society of Travel Medicine conference in Basel 2 years ago, about 3.5% contracted COVID, but there was reporting bias in that, because it was a general survey went out saying, can you tell us whether or not you contracted COVID during the conference? And probably those who did were more likely to respond to the survey. And there haven't been any more recent studies, so we're not sure what percentage of travellers are contracting COVID. RSV, there's very little data specifically in travellers. A large Chinese study published in 2020 suggested 1.7 cases per million travellers, which is very, very small. Pneumococcal disease in travellers, it's really anecdotal cases. There's a case series from mass gatherings. There were 4 cases, one of which was fatal, which was published back in 2019. Pertussis, again, geosentinel clinics, they had 74 cases over 6 years reported, but again, they have no denominator data, so they don't know what the incidence is, and certainly don't know if the risk is higher than travelers compared to non-travelers. But I think it's reasonable to assume that, I mean, travel is all about risk mitigation when people travel across a risk gradient. And this was a very interesting map put together in this paper by colleagues in the UK, looking at the prevalence per 100,000 population of pneumococcal disease. And you can see that a lot of low and middle-income countries have a much higher prevalence than incidence and prevalence than we do, and there will be a risk gradient then, which means people theoretically you would expect would be higher risk of pneumococcal disease during travel. So that moves us on to vaccination for older travellers, and we often talk about the 3 Rs: the routine, the required, the recommended, this framework that we use thinking about vaccines and travellers. It's a very artificial division because all of those routine vaccines, of course, will benefit the traveller while they're travelling as well. But the reason I still like to separate out the routines is that a lot of the routines, not all of them, but those first four I've listed there, influenza, COVID, pertussis, tetanus, diphtheria, and herpes zoster, those vaccines are all funded in for most certainly over the age of 65. And so this is the pre-travel consultation serves as an opportunity to ensure that anyone who is eligible for funded vaccines is actually getting them. And often it's the impending travel that's that little bit of that extra incentive they need to actually go and get the vaccines, because I say, well, look, you're eligible for free influenza, COVID, and you haven't had your 65-year-old tetanus booster yet. You don't want to get any of these diseases in the weeks, months leading up to your trip, or you want to reduce your risk, and you don't want to get them while you're traveling. So why not take the advantage now of getting those updated? And of course, you want to get your shingles done as well if you're eligible and not yet had it. Pneumococcal and respiratory syncytial virus. Pneumococcal is funded for a specific subgroup, and I'll come to that in a moment. At the moment, so respiratory syncytial virus is recommended, but there aren't any funded indications yet. Then you have the required vaccines. They may require yellow fever, meningococcal if they're attending the Hajj or Umrah in Saudi Arabia, and polio is currently required on exiting, proof of polio vaccination on exiting certain countries, not to enter. And then you have all the recommended travel vaccines. So if we go to pneumococcal, so these are the funded indications. This is from the New Zealand Immunisation Handbook, and I'm sure you're all familiar with this. This is for adults over the age of 18. And then the unrecommended but not funded, and you see down the bottom, adults aged 65 years or older with no other risk factors. And the other important point that they make in the immunisation handbook, of course, is this concept of risk stacking. So there are high risk conditions where the vaccine is recommended, but there are also at-risk conditions, and if you had a number of at-risk conditions, they could stack and actually easily surpass the threshold of a single high-risk condition. It's difficult to quantify that, but it's something to think about when you're recommending vaccines for your older adults and travellers. RSV, as I said, is Rexv is indicated for active immunisation in those as 60 adults 60 years of age and older, but it is currently unfunded. It can be considered for individuals who are aged over 60, especially the very elderly and those with multiple comorbidities that increase the risk of severe RSV. And it's offered as a single dose. MedSafe have just expanded the use down to 50 years of age for those at risk of severe disease. It's not yet on the MedSafe website, and it's not yet been changed in the immunisation handbook, but you should be seeing that coming through soon. And again, I like to acknowledge Prof. Robert Steffens for this beautiful, elegant slide that he made talking about vaccines against acute respiratory infections, thinking of the string quartet. So you have V for the violins, and the viola, the viruses. So SARS-CoV-2, influenza, RSV, and then the base for bacterium, pneumoniae, but also pertussis. So when we look, this is all backed up by, this is, anyone who's ever done any travel medicine will have heard me talk about the Stephenogram many times. So again, this is Robert Steffen. Over the years, he has developed this logarithmic scale, looking at the incidence rate of specific diseases, on the risk of vaccine-preventable diseases in an unvaccinated traveller per month of travel. And these are best estimates. These are not fantastic. They're not highly accurate, but they're the best. And the most important point here is that the two most common vaccine-preventable diseases in travellers are currently COVID-19 and influenza, way ahead of your hepatitis A, which is right down the list, way ahead of typhoid, and all the other things, the vaccines that we think of routinely during travel, and especially in our older traveller, because we know older travellers do less well with both of these respiratory diseases. And if you can't do anything else, if you can get COVID and influenza into them, then you're doing them a real service. So back to this immunosenescence and why it's so important in vaccination. And if you want to read a really good sort of generalist article on immunosenescence written by a non-medic but a science writer, then I'd recommend this paper to you. You're only as young as your immune system. Looking at all the different components of the immune system, every one of them doesn't work as well as we get older, even in the healthiest older person. The lymph nodes aren't as plentiful. The germinal centers, where so much of the business of T cell and B cell stimulation starts, that is just not as efficient. The dendritic cells, which take up the antigen and present the antigen in the germinal centers, don't work as well. They don't pick up as much antigen. They don't express them as well. There are fewer of them. The T cells diminish because the thymus gland shrivels up and becomes less effective. And the B cells in the bone marrow don't do as well. There just aren't as many of them around. There's fewer memory cells, fewer plasma cells. So every component of the immune system gets a little less efficient as we age. And we know that, and that's why older people don't do as well when they become infected. So this was the hospitalization admissions by age for COVID in New Zealand. Those older age groups had much higher hospitalization admissions, reflecting more severe disease. The immune system becomes less capable of keeping infections in check. So this is herpes zoster, and from many countries we see, and it starts at about 50, this very steep rise of shingles in people, because the immune system's just no longer as good as it used to be at keeping that the virus in check in the dorsal root ganglia. Influenza vaccines, this is 85 studies of vaccine effectiveness, so how well it's controlling disease in the population. And up on the top right, are the very young, and then it becomes a little less effective in the middle age group, and less effective again in those over 65 years of age. So vaccine effectiveness drops. So in the older person, there's lower antibody seroconversion rates to vaccines, there's poorer antibody affinity, lower antibody peak titers, a slower rise in antibodies, a more rapid antibody decline. Cellular immune response is also slowed, plus older people are more prone to side effects and adverse events to the vaccine. But all is not lost. There are mechanisms, there are strategies that can be employed to try to stir up and stimulate that aging immune system. High dose vaccines, multivalent vaccines, and more recently adjuvanted vaccines, and these new novel adjuvants which stimulate the immune system. There's also work going on, I talked about before, this chronic inflammation, and this chronic inflammation um, stresses the immune system and makes it less effective. And if we can block the chronic inflammation in older persons, we may be able to enhance vaccine response. And there's been some work done on that. So I've summarized that all again in the next slide, but I've just highlighted, the adjuvanted vaccines. We've now got influenza, herpes zoster, and RSV, and we can also play around with so the messenger RNA vaccines actually were highly effective in older persons, but we could also perhaps do more boosting, or we could delay the intervals between vaccines. We can use different routes, but really the growth at the moment is all around these adjuvanted vaccines. Live attenuated vaccines tend to give a really good immune response, and often certainly for duration. But in older persons, they're more likely to have precautions and contraindications. Not saying you can't use them, but you may have to be more cautious in their use. So coming back to adjuvants, and this is a pictorial representation, basically the way I think of it, an adjuvant is something that's injected at the site where the vaccine is injected, and it causes irritation. It annoys the immune system, so it attracts the dendritic cells and the macrophages to the site of the injection, and there are many, many more of them, and then take them to the lymph nodes and the germinal centers, where you just get an enhanced amount of naive B cells, of B memory cells, of antibodies, and the cytotoxic T cells. So it just shakes up the immune system, and we've got good evidence now from a number of vaccines. So this is a recent review of the RSV vaccines in the USA, a CDC presentation. They've got 2 adjuvanted vaccines there. In the blue are the vaccine effectiveness in the trials, the drug company run trials, and you can see really very, very effective, up in the 80% plus. And in the third column along, you can see the age ranges. You can see how many of people in those studies were older people, and some up to 99 years of age. And then in the red, the next block down, was RSV associated hospitalizations. And so this is real world data. This is effectiveness data. What happens when you vaccinate a population against RSV? And what they found was the protection against RSV associated hospitalization in real world data was much the same as that seen in the clinical trials, and up at the 80% plus, which is really, really good. Adjuvanted vaccines also, there's evidence of longevity. Now, we haven't got a lot of long-term data with RSV at the moment, but we do with the zoster vaccine, the recombinant zoster vaccine. We've got data out to year 11 now, and 82% vaccine efficacy against shingles, which is pretty astounding. And although I haven't broken it down by age groups, but the older age was a bit lower than the younger age groups, but it was still very, very good. But what do we know about the impact of age on travel vaccines and vaccination? And there was this good paper published, but it was back in 2001, and they summarised there was some evidence of diminished responses to hepatitis A and rabies vaccine in older individuals, but the main conclusion was many travel-related vaccines have never been studied specifically in elderly populations. Since then, there was a little bit of work done on yellow fever, and this is 2011, and compared the antibody titers and the RNA copy number of the yellow copies of the yellow fever virus vaccine up to 28 days post vaccination, and they compared 18 to 28-year-old group with those over 60 to 81 years of age. And two things are important here. By day 28, on the right hand of the graph, both the young and the old had comparable conversion rates. So that was really interesting. But what I'd like to draw your attention to is on the left side of the graph, you can see in the early days, the older subjects were lagging behind the younger subjects. So, yes, they achieved the same antibody titers eventually, but they took longer to get there. And that has implications, and why in one of my later slides, I suggest that it's really important that we aim to vaccinate our older travellers as far in advance as we possibly can. So you could still do it last minute if you had to, but the earlier you get it in, the better. And this is another yellow fever vaccine study that showed it was only a small study, but both the young and the old all were still seropositive 10 years after primary vaccination. And the mean geometric concentrations were a bit lower in the older age group, but they were not statistically different. Japanese encephalitis, the inactivated one, this is JSPECT, looked at 200 people, and this one found that their seroprotection rate was around 65, whereas in younger people it's about 90, it's 90% plus. But their conclusion was that 65 is as good as many other vaccines that we use in older persons, and so it's still pretty good. And yeah, 65% protection is still better than none. But they did suggest that perhaps ensuring that if people were on ongoing exposure to Japanese encephalitis, then a third dose should be considered before any further exposure to the JE virus, although we recommend a third dose in immunocompetent younger people as well. So in a summary, the hepatitis A vaccine seemed to have lower seroconversion rates, although it's still very, very protective. It's still very high. But there are no studies in those over 65 years of age. If you can get 2 doses in before they travel, that's a good idea, and vaccinate as early as possible. Hepatitis B, we know from many, many studies, lower seroconversion rates in the older. Some suggest it may be worth checking serology to ensure they've seroconverted. There's no data on older travellers in either of the typhoid vaccines. See, the rabies inactivated intramuscular route, there's mixed results, but it's of uncertain clinical significance. So even if the seroconversion rates were slightly low, or the antibody levels were slightly lower, we have such a such a buffer of in rabies that a slightly lower seroconversion rate is probably of no great clinical concern. Intradermal, there's very limited data, although some people suggest we shouldn't be using intradermal in older persons. Some evidence perhaps they have a lower response. But the point here is the practicality. As you lose connective tissue or the robustness of the connective tissue, then it may be more difficult to administer. As I've mentioned, the Japanese encephalitis, the live attenuated vaccine, which is only available in New Zealand under Section 29, there's no data in older adults. The chikungunya vaccines I won't go into. We haven't got access to them here in New Zealand. There is some good data showing they have good seroconversion rates, but at the moment there's a major concern around severe adverse events in the live attenuated chikungunya vaccine, and there's been a current pause on administering it to older persons. Similarly, the dengue live attenuated vaccine, which we don't have easy access to in New Zealand, very limited data, and there's no data in those over 60 years of age. And yellow fever, maybe a slower antibody response to administer as early as possible. But the big issue with yellow fever is the increased risk of severe adverse events. So we have to have a very individualized risk assessment as to whether or not it's safe to give that person. Moving on quickly before I wrap up with safety concerns and insurance, again, in the survey of New Zealand seniors, a lot of their safety concerns were around unexpected medical costs, being hospitalized, having accidents, adequate medical facilities, um, much more so than younger travelers. So it is something that older travelers are thinking about. And in this study, 91% of those who are traveling overseas would take out at least basic cover, 34% basic cover, 57% would comprehensive cover, but that still leaves almost 10% of our older travelers who are traveling without travel insurance. Now, that might just be because they can't get it or they can't afford it. And I'm not so concerned about those who aren't traveling with insurance for domestic travel because they'd still have good access to medical care. So let's go back to our 81-year-old, and this time he saw his GP pre-travel. He got a good medical letter and he sorted out all his supplies. He got a hypo kit and discussed how to recognize a hypo. He discussed his insulin and thought, well, actually, it's better to run a little bit high than risk a hypo. So given the hassle and things, skipping one day of isophane during his flights and his travel to the UK is not going to be a big deal. He got a medic alert bracelet. He got all his vaccinations. He got his below knee compression socks. His son would stay with him in Wellington and made sure he got everything checked through okay. And most importantly, he contacted the airline medical assistance unit and they arranged for him to be met at the gate in Auckland, Dubai, and Heathrow so that he could negotiate all his transits a lot better. And he arrived in London far more refreshed, far less confused and tired, and not in hospital. So in summary, the older traveller, your pre-travel preparation, all travel medicine is an individualized risk assessment. So an older traveller still needs an individualized risk assessment because there will be a huge range of need from in older travellers. They are more likely to have pre-existing medical conditions, and the best advice you can give your travellers about that is to ensure that their pre-existing medical conditions are under optimal control. We have to take into account immunosenescence, and that may put them at higher risk of infections and give them good appropriate advice around that. We need to vaccinate early, and we need to be using the increasing number of better vaccines that we have for older travellers, and hopefully we'll have more in the future. Advise our travellers to get into physical shape as much as possible. That will protect them against injury, against falls, against all sorts of problems while they travel. Try and reduce your travel stresses. So take your time, pre-book things, and think about things in advance, and make sure you get some good travel insurance. And I was looking for a very witty quote to finish with, and I was watching TV the other night, and this is the current life insurance advertisement that's on television saying you don't stop doing things, or you don't stop doing things because you get old because you stop doing things. So I think it's fantastic that our older patients are traveling, and hopefully we can do something to keep them safe while they're traveling. And I've put a whole lot of references there if people are keen to look at them later. So I'll stop there.
Thank you so much, Jenny. That was fantastic. There was a question at the start just regarding particularly joint prosthesis, cataracts, and immigration. Any comments regarding transit, immigration security, and that sort of thing?
You need joint prostheses setting off the
Metalware, so
metalware, yeah.
cataracts and replacements, metal issues for MSK and immigration.
There is, it's great. You're going to set off the alarms, and you might be moved then from going through the general to the body scan. They'll very quickly pick up where it is on the body, and then they'll just do a pat down. And if it's a prosthesis or something, you're going to set it off. You can't remove it. And I think if people have got concerns, I think a doctor's letter can go a long way to help reduce their anxiety, and yeah, if it is if it is metalwork or whatever, then it is going to set off the alarms. But in the pack down, would be obvious that you're not carrying anything dangerous.
Cruises.
Cruising.
Any study on cruises?
There are many, many, and that's a whole lecture all on its own. And the two big diseases in cruises are influenza. Well, there's three now, isn't there? COVID. I mean, we saw that. I mean, that the horrible those cruises that were caught and then left in important things while everybody caught COVID. But influenza, there's lots of studies, and there are many, many outbreaks of influenza recorded in cruise liners. Norovirus is the other big one, just rips through so hard to eliminate. But also there's been measles outbreaks, varicella. It's and it can affect crew and passengers. So I think just all those respiratory vaccines, all of those ones I talked about, if you can, especially in your older travelers, but everybody, certainly everyone should get a flu vaccine and be up to date with their COVID boosters, and and good advice around hand hygiene. But the cruise companies have learnt from particularly norovirus outbreaks and things, and they have very strict controls and hand washing and hand gel and things, because it really is it can shut down a whole cruise. So yeah, floating petri dishes they've been called, and I think they are. And all we can do is try to get as many vaccines and give good sensible advice.
So, what resources and supports are available for those of us doing travel medicine and primary care? We are in an area where there is no travel clinic, no travel centres, and finding it hard to get advice for questions and so on.
Okay, couple of things. I mean, there are good online resources. The CDC Yellow Book is a really good general textbook on travel medicine, but you probably don't want to be reading that with a traveller in front of you. The Increasingly, I turn for general advice to NAFNAC, which is the UK website. It's very well written. It's got lots of patient handouts. It's got lots of information for clinicians. It is a UK based, so not all the vaccines that they have, the licensing and the approval for uses isn't necessarily the same. Um, in Certainly in urban centres, but this doesn't sound like an urban centre. I mean, setting up a travel medicine peer review group, but probably people don't have time to do, or you may not have the resources to do that. Join the New Zealand Society of Travel Medicine. I've told you I don't do social media, but I do know that there's been a Facebook page has been set up, and sometimes people will put questions in there. And certainly, I can't answer every question, but if you have a difficult patient and you've got concerns, you can always talk to your peers who are doing travel medicine, contacting people like myself or people through the New Zealand Society of Travel Medicine. The International Society of Travel Medicine has a very good, used to be listserv, it's now called the Travel Health Forum, and you can post questions and get responses there, but it's an international audience, and you have to become a member of the International Society of Travel Medicine. Don't know if that answers the question, but go and look at NAFNAC website. It's got great resources.
So, any sort of information on evacuation and repatriation rates for aged folk?
How often they're repatriated? No, I don't know a figure off the top of my head, and actually I don't know if it's that much higher than younger people, because, um well, it probably is higher than younger people overall, but younger people have more severe injuries and things, motor vehicle accidents, particularly in low-income countries. If you look at all insurance claims, I'll have to have a look at that, but all insurance claims, I don't think there's a significant weighting towards older people. Travel insurance? Yeah, not sure.
And in sort of similar line, utilization rates of medical services and hospitalizations while away.
Yeah, so that 5%, That one, so the Dutch study showing 5% had an exacerbation, and I think from memory it was about a 1% hospitalization rate. And other studies have shown that in the general population as well, the general traveling population. Yeah.
Why is the shingles vaccine only funded for 65-year-olds?
That's not my
You can answer.
That's a funding it's a funding course. I mean, I know that many, lots of applications have been put forward to Pharmac to extend the, so it's not isolated just to the people. You don't have to do it in your 65th year, if you turn up the day after, but that it's a funding decision, and we can only continue to put pressure on to open it up. Yeah.
So some travellers, particularly 30 to 50-year-olds, mainly depend on their immune systems when travelling and are not keen on being immunised for respiratory infections. What is your advice to those travellers in terms of travel vaccine administration, and how
I
can
mean,
health care practitioners leverage
yeah,
this
yeah.
conversation?
Again, I think influenza's quite straightforward because, it's cheap. It's it's not a huge expense. It is recommended for everybody in New Zealand. It's just not funded for everybody in New Zealand. So, I just say, look, and when people say, look, I've never had influenza, I said, well, that's great. Getting the influenza vaccine isn't going to change that, but it might just increase your chances even better that you're never going to get influenza. We're very lucky that we have a combination tetanus, pertussis, diphtheria vaccine. So often travellers in that age group will need a tetanus booster pre-travel because they're going remote or to low and low middle income countries. So they're getting their pertussis booster at the same time. And it's been really interesting this year and last year with the whooping cough outbreaks, saying, oh, well, the tetanus comes combined with your whooping cough booster and diphtheria, and they go, oh, that sounds good. So it's almost it's another little, well, it's three for the price of one, basically. And again, it's not a horribly expensive vaccine. And I just come back, I just say to anybody, saying anybody over the age of 30 is eligible currently for a funded COVID booster if it's been more than 6 months since the last COVID shot or they last had COVID. And if it's free, why not do it? And, when I mentioned, a lot of people don't understand, don't realize that they are actually eligible for a COVID booster. They're thinking it's only for people with mobilities. And yes, it's particularly targeted at those people. But for a younger traveler, this might be the incentive to get it. So I just mention it to all of them, say, look, you don't want to get these things just before you travel or while you're traveling. They're either free or not horribly expensive. Why not do it?
And what was your remark about the yellow fever vaccine risk? Um,
Yeah, so and I didn't have time to go into that, but we know yellow fever vaccine specifically has this serious adverse events. It is associated with a number of serious adverse events, and the risk appears to go up over 60 and then again over 70. Although at the conference I was at recently, the German authorities have done a big reanalysis and meta-analysis and systematic review and actually say that there isn't good data behind that. But most people would still say that once you're over the age of 60, it's a precaution to receiving the yellow fever vaccine. It is not a contraindication. You can do, because the yellow fever vaccine virus can produce a yellow fever-like disease, and there have been about 100 recorded cases of this, documented cases of this globally, and it has about a 50% case fatality rate. So we only currently give the yellow fever vaccine to people who are actually, if they're over 60, if they're actually going to be at risk of exposure. So if there's only a requirement to show proof of vaccination because you're coming from a country with a risk of yellow fever, but you're not actually going into a yellow fever area, then we would be likely to give an exemption letter rather than the vaccine.
Great, thank you. And this one's not necessarily related to the older traveller.
Yeah.
Can you please explain if for a live vaccine administration, what happens if you give them less than 2 weeks apart? For example, if a person had an MMR and then had a yellow fever vaccine 2 to 3 weeks later, will it affect either vaccine?
Yes.
We've been seeing some people who have been getting MMRs
Yeah.
due to the outbreak and
Yep.
then
Yep.
receiving other live vaccines.
Yep. Yep. So the general advice is always that live vaccines should be given either on the same day or 4 weeks apart, because they can interfere with the response. You just see a lower seroconversion rate in any one of the vaccines that you're giving. The yellow fever MMR one is interesting because there have been a couple of studies that have shown that if you give them together on the same day, you do actually get a lower seroconversion rate in the measles and the yellow fever, and I think in the mumps as well. So actually, for yellow fever and MMR, most guidelines currently say that try to give them 4 weeks apart. If you can't, give them on the same day. If you have to, if they need cover for both, you give them on the same day. You're still getting reasonable seroconversion, but it's just blunted across and I'm sure it's measles, mumps, and yellow fever. But if you have got 4 weeks, then space it by 4 weeks. If you're giving yellow fever, one of the questions you must always ask is, have you had another live vaccine in the last 4 weeks? And if you're not asking that, or you should actually be asking, have you received any other vaccines in the last 4 weeks? And if they've received MMR, then you should wait 4 weeks to give the yellow fever. Now, if the travel is if they're about to leave and they haven't got 4 weeks, you can only give it in the time frame you've got it, but you have to then assume that you're going to, it's possible it will blunt the response to the yellow fever vaccine. And some would argue that it should then be not counted and be given again if it's needed again in the future. But it's really difficult to quantify how much is it blunted, because everyone's immune system will react quite differently. And many people, you could probably give 2 live vaccines um, closer than the 4 weeks, and they'll probably be fine. But the general rule is 4 weeks, same day or 4 weeks apart.
Do you routinely recommend non-funded shingles for those 50 plus years when travelling?
Yeah, yeah. I mean, I'm in the travel context because all my clinical medicine is now is in travel. I will ask people if they've had shingles, or they've been vaccinated. Sorry, if they've been vaccinated. And certainly those who are coming close to their 65th birthday said, make sure you don't, make sure you go and get the funded vaccine. And say, but the risk does start as early as 50. If you're very keen, we could bring the vaccine, or we keep one in stock. Or if you're not interested before this trip, then this is something you can discuss with your GP when you get back. And certainly, and given the longevity now, we've got the evidence that it's really great, at least out to year 11 and possibly longer. Getting vaccinated early um, is becoming more of a viable option, I think, for a lot of people. But it is expensive, and it has to be self-funded under 65. Yeah.
And for those heading towards the northern hemisphere at the end of the year, common
Yes.
trip, do you
Yes.
encourage them to have that second influenza dose
Absolutely.
if they can access it?
Yeah,
Yeah.
yeah, and that's and it's good now that the influenza vaccines, now we have an expiry date out to end of January usually. So, yes, if someone was vaccinated this winter, if it's more than 6 months and they're heading off into the northern hemisphere, give them a second dose of our vaccine. If we could easily get the Northern Hemisphere vaccine into New Zealand, we've tried it before, it was very expensive, there wasn't the uptake. Even if there isn't a perfect match between our vaccine, the Southern Hemisphere vaccine, and the Northern Hemisphere vaccine, it's still worth giving because there is some cross protection. And if it's somebody really highly at risk, they could also consider then, if they could arrange it, getting the local vaccine on arrival, especially if they're there for a significant amount of winter. But absolutely give them a second dose of this year's vaccine. Yeah.
We'll just do a few final questions. Do you recommend N95 or surgical masking on long haul flights?
Yes, yeah, absolutely. And those I didn't have time to talk about the non-vaccine. I think using masks and hand hygiene and things is still very important for avoiding all of those. Interesting, coming back from the States just yesterday, very few people are wearing masks now, but there are a few. But certainly our older travellers, I would advise. Yeah.
There's been a lot of people who have been asking whether this is the sort of knowledge that most GPs should have, or whether they should be referring people to specialised travel clinics.
Yeah.
Yeah, so maybe just a final comment on that to
Final
wrap
comment
up.
on that. I mean, first of all, come and do our postgraduate certificate, come and do our papers, enroll in our papers. I know it's, to study. So at Otago University, we offer a certificate in travel medicine. Which consists of 2 papers, which you can do part-time over a couple of years. But that's a big commitment, but it is lots of fun. And Danusha's been you're one of my graduate students, so I'm sure most people enjoy it. So there's that opportunity. Um, I do think if you're doing primary health care, you've got to have some travel medicine knowledge. I mean, nearly all travel medicine is delivered within primary health care in New Zealand. But like everything in primary health care, if you don't feel you're within your scope and you can't manage it, then yes, refer to a colleague, and it doesn't have to be a standalone travel medicine clinic. I'm sure you may have colleagues if you're in a big group practice or the practice down the road. Find out who does do travel medicine, who has got some qualifications in travel medicine. Come and join the New Zealand Society of Travel Medicine and come to our conference. We try to keep the fees really low. We have an annual conference and we do an ABC before every time. On the Friday, we do a workshop for introduction to travel medicine, and it's free to join the New Zealand Society of Travel Medicine. And our conference is in November. I think it's that 6th, 7th, 8th of November this year in Christchurch. So that would be a really good starter as well. But if you don't feel confident doing it, feel free to refer on.
Thank you, Jenny. Once again, thank you for everyone for joining us tonight. So thank you very much.
Thank you.